Right. You're recording. Can you see my screen?
No, we can't see the screen.
Can't see anything yet? No.
No, still nothing, just KH.
Oh, that's no good. Let's see. No, still not.
No, sorry.
No, that's okay. No, the camera. See my own meeting in calendars. I love it. Surely enough, the others can see it.
Hamad, we can see, but we can't hear anything anymore.
Sorry, I muted myself. Right. Okay, so you can see and you can hear.
Yeah, we can. Thank you.
Awesome. Great, and we're recording, and also Eugene's pointing a camera at me. So there's all sorts going on here. Right. Okay, sorry about the delay. We got there eventually. So I thought it'd be good to talk a little bit about hypotension and inotropes, because I think it's something that everyone gets worried about, confused about, not sure. Why do we choose that inotrope? What number is bad for hypotension? What is happening with this baby? I'm really scared. All those things pass through your head. I know they pass through my head on a regular basis. So, first of all, to do both at the same time. Right. First of all, can we define hypotension? Can someone do that for me? Define hypotension. Come in. We literally just started. We talked about our anxieties and uncertainties around the clinical management of babies with hypotension. We had a little bit of a group discussion. Everyone gave their piece. It's okay, you guys. It's fine. You don't have to. You don't have to. So, but you can help by helping us to define hypotension. What's that then? Low blood pressure. Brilliant. Thanks, Jess. So Jess is straight in there with low blood pressure. And guys at home, are you chatting on the? Maybe I should join on my phone as well, and then I can see the chat. This is so. Ooh, it's very quiet. Can anyone see or hear any? Can you all hear now? What time was that?
Yeah,
we can hear and see,
Yeah,
Hamad.
Okay. Oh, yes. Great. Excellent. Thank you for confirming. Right. And does anyone have any comments about hypotension? You can type them, and I'll see the messages. I've now got 5 screens in front of me. This isn't crazy at all. So low blood pressure start for 10. Low blood pressure. Poor perfusion of end organs. Someone straight in there. Admin at gstT969 on Microsoft. Who is that, by the way? And Rachel as well. Inadequate perfusion of organs. I don't know. Have you guys heard this before? What? No. Okay. No. Hypotension. I said hypotension. Thanks, Claire. I said hypotension. I don't know what. But what's perfusion? I said hypotension. So I'm with Jess on this because hypotension is low blood pressure.
Mean blood pressure below the gestational age.
But it's on the screen there. So that's good. So mean blood pressure below gestational age. What else? What else could it be?
I correctly remember there's Zubrow's chart based on.
Oh, there's a chart. So there's a chart as well. You could say below the 10th centile for that gestation and postnatal age. You can have a chart, and it will depend on the age and the gestation. And so you have and the guys joining on the thing are still insisting on the inadequate perfusion of organs, but that's okay. Oh no! Now we've got
like cardiac output and all of that makes up high blood pressure.
Okay. So what?
It's not just the.
Yeah. So I guess the question I asked was what was hypotension, and so strictly speaking, hypotension is low blood pressure. And how more accurately we might define that is some people have chosen mean blood pressure less than gestational age as a way of doing that. Other people have said, okay, well, below the 10th centile for gestation and postnatal age, that's more refined, but that's still just a number. Yeah. So what does that number mean? What should we worry about? So one of the nurses says this baby's hypotensive. When should you worry? So perhaps then we come back to the inadequate perfusion of organs, as it says here. So any blood pressure below which there's inadequate blood flow to support perfusion. So then that brings us to perfusion. And so we stop worrying about hypotension and instead worry about perfusion. But then you need to define perfusion. Oh, you see, now you just let yourselves down the rabbit hole. So you guys at home, you tap away on your screens.
Oxygen.
Is it A, oxygen delivery? Is it B, glucose delivery? Is it C, both?
Delivery of all the things you need and removal.
Or is it D, delivery of all the things you need and removal of them?
Yeah.
A, B, C, or D? Press your buttons now.
No coffee.
You can go 50-50, phone a friend. Oh, someone was going to say something, but they didn't. Is it all of those?
D.
D, someone? D, all of those? Yeah, maybe. I mean, strictly speaking, it's just oxygen, but then oxygen's no good without a bit of sugar. And hopefully, if we do one, we'll do the other, unless you're pumping in wet and then you occlude your venous return. That would be a bad thing. But then eventually, that's going to stop the supply of oxygen and sugar. So delivery of adequate oxygens and nutrients to the end organs. So that's a nice definition. But what does that depend on? What does that depend on? So cardiac output, yeah. Systemic vascular resistance, cardiac output. So those are the two things that define blood pressure, CO and SVR, right? So blood pressure is only part of the picture. Can you imagine a situation where you could have low blood pressure but good perfusion? Yeah. With adequate cardiac output.
Like the other way around, you could have low sats. You could have like a cardiac baby that's got like 50% sats and great blood pressure, but they just don't have the oxygen delivery. So
yes. So if you didn't have the oxygen carrying capacity, oxygen in your blood, then it doesn't matter what your flow is. It doesn't matter what the actual blood going into the end organ is. So it's dependent on, so flow is essentially the description that you've got blood going into that organ, which is dependent on having an adequately low systemic vascular resistance, too high, and it's not going to get there, but also adequate cardiac output. And blood pressure, perversely, the higher it is, then as a function of cardiac output and SVR, the higher your SVR, then the higher your blood pressure. So in some ways you might say, well, no, that's no good, because we use blood pressure as a proxy of cardiac output. It is also influenced by SVR, and that's the thing I want you to sort of recall and remember when we're thinking about blood pressure. So flow, more important than just blood pressure or cardiac output or SVR, adequate flow and adequate oxygen carrying capacity of blood. And then don't forget your, press close to these. So don't forget your oxygen hemoglobin dissociation curve. Yeah? Because obviously the oxygen carrying capacity of the blood is going to depend on lots of other factors as well. So things that are increasing the affinity of hemoglobin for oxygen mean that so such as lower CO2 and less pH are obviously going to improve the oxygen carrying capacity. And then, of course, you've got to think about how do we know if there's enough oxygen going to those organs? What is enough oxygen?
Just enough to maintain like the function of the organs.
Yeah, which might change, is the point. Yeah. So you've got to match supply to demand. So a baby who's septic, or if they've got a VAP, for instance, or if there's something else going on that's going to increase metabolic demand, then their oxygen demand is going to increase. So for the same supply, you're not getting perfusion. Yeah. So all of these things are going to be important. So the takeaway summary is good blood pressure does not necessarily mean good flow. Therefore, good blood pressure is not always good perfusion. Yeah, and you've got to look at all of those different things. Right. Is that enough for today? I don't know. Slide 4 of 16, it says. We'll carry on for a bit. Carry on for a bit. So, how do we know if we have poor perfusion? And this is a game that you can play along at home. You need to join in, guys. How do we know if we have poor perfusion? So, I present to you the situation again, 26-weeker, and the nurse looking after the baby says the baby's mean blood pressure is 25, as measured through the UAC that you just put in. What are you going to do about it?
Assess the baby in terms of other parameters, so heart rate, capillary refill time, and urine output.
Huh? Yeah. So someone has said crude. Oh, capillary refill time. Yeah. Crude, poor urine output, low tachycardia, high lactate, poor. So all the, and Nikki's just said, look at all the parameters, which I love. So I'm gonna make you choose an organ. Yeah, because organs are being perfused, aren't they? We hope. Yeah, so the organs are being perfused. So name an organ, and so you started with, what was your first thing?
So it said it's tested, so it says heart rate.
Yeah. So, well, someone said capillary refill time. So what capillary refill time? What organ is that? What are we looking at?
The skin.
The skin. Okay. So what are all of the different things that we can see in the skin?
So color.
Yeah.
The refill time.
What color?
So whether it's pink or cyanose.
Yeah. So whether it's pink or cyanose. So cyanose tells us about oxygen.
Oh, yeah.
Yeah. What else in skin? So mottling, capillary refill time. So that tells us about flow in skin. Yeah. Are we thinking about it a little bit more in the round? Yeah. So when you're looking at the skin, one of the first things you do when you approach child is to look at them. And you can immediately tell so much information from the perfusion of the skin. And the thing that you're looking at is important to think about. So cyanosis is low oxygen, whereas mottling or low prolonged capillary refill time is flow as a measure of perfusion. Sorry.
And what's comparing central to peripheral?
Yeah.
Refill be helpful?
Yeah. So you raise a really interesting point. When we think about all of this, when we think about different organs, it's also important to remember that not all organs are equal. Yeah? So when Jonathan says peripheral versus central, then what's that a reflection of? Anyone at home as well can tap away or unmute themselves and just shout. Yeah, glasses, toe core gap temperature. So systemic vascular resistance, yeah? So one of the first responses to a poor perfusion state is to increase systemic vascular resistance, but to specific organs. Yeah. So the peripheries, they tighten up. So you'll immediately get cold hands, cold feet, a difference in capillary refill time between central and peripheral, and Claire has said toe core gap temperature. So immediately that gives you information. Okay. And what are the important organs? The brain, the heart, the kidneys. The liver's quite important. As much as we hate to admit it, the liver's quite important. What are the expendable organs? The gut, sadly, yes. The gut, the skin. Yeah. Skeletal muscle. Yeah. It's expendable. The brain. Katerina says brain. I think she was answering the question before about what was important. I hope. So, yes, she says yip. So, another organ, please. Kidneys, great. So it's that skin, the little thing, skin.
Just naming these in the order that you've got.
Yeah. Did you not know that? Okay. So, so kidneys. So how do you know if the kidneys are well perfused? It's a trick question. How do you know if the kidneys are well perfused? Producing urine is the correct answer. Slightly yes. In which situation will the kidneys be well perfused but not produce urine? Nikki says you, as in UO. Urine output. Yeah. Correct, Nikki. You're with Jonathan, and that's 90% the correct answer. When is it not the correct answer? Okay, so you can exactly. So you can imagine a state where the kidneys have suffered an injury and are now well perfused, but are just being very stroppy, and says that they're really upset and they don't want to play. They're not going to make any urine for at least 3 days. Yeah, they're basically like petulant. I mean, choose your child, anything from toddler through to teenager, really. But a petulant child who's been upset by something and they say, well, I'm not playing now. Yeah. So ATM. In our experience of the babies, is there another situation in which we see poor urine output? That's okay. Specifically thinking about the babies.
Before they're like diarrhea.
Before their diaries in first 48 hours. Okay. First 48 hours, you've been very generous with your time there. Katerina says retention. Yes, thanks, Katerina. Yes, so retention as well. Yeah, so you're not going to wee if you've got blockage. Yeah. So good point. First 48 hours, quite generous. When do babies normally start peeing? 12, 24 hours?
Yeah.
Normally, if they haven't peed by 24 hours, I'm a bit worried. Yeah. But normally there's a little bit of a delay. When is that delay prolonged? Okay, let's go back to fetal circulation. You weren't expecting that, were you? You weren't expecting that. Let's go back to fetal circulation. Okay. Okay, let's then Nikki says within 24 hours. So yeah. So fetal circulation. You all got it in your head?
Yeah.
Yeah, okay. Now transition from fetal to adult type circulation.
Yeah.
Okay? So duct closes, that's one. Okay?
Lung resistance falls.
Lung resistance falls, massive increase in systemic vascular resistance with the clamping of the cord. Yeah? After adequate delayed cord clamping, obviously guys, the accusatory eyes in the room. Guys, you can't see this. It's terrible. I'm being judged. So after adequate cord clamping, then sudden increase in the systemic vascular resistance, and with time a reduction in the pulmonary vascular resistance, yeah, closing of the duct, and because there's then a difference in pressure between the left atrium and the right atrium, lower pressure on the right side, higher pressure on the left side, indicated the slapping closed of the foramen ovale, and the foramen ovale closes, yeah, and then the pressure in the left atrium is increased, yeah, and also because there's more venous return from the pulmonary circulation, and that triggers what? Atrial natriuretic peptide, yeah? Atrial natriuretic peptide? Everyone like a bit of AMP? Yeah? Everyone likes a bit of AMP. Yeah? You take a drink, yeah? And then AMP, and then whoosh, or wee, whatever. Yeah? Great. In what situation might that be delayed? Think about all of the things that go into that.
Got a massive ASD.
Okay. Lungs. So anything that stops your vascular resistance from falling, yeah? Anything that stops your pulmonary vascular resistance from falling will stop that production of AMP. So what are the clinical conditions that can lead to a slowing of a reduction in pulmonary vascular resistance? Now, it kind of is a question. Well, what are the causes of pulmonary hypertension? Of the persistent pulmonary hypertension of the newborn? You guys at home can MECASP, Claire says, yeah, MECASP, great, okay. Anything else? Sorry?
Congenital pneumonia.
Congenital pneumonia, great, yeah. Idiopathic or secondary? Idiopathic. Whoa, idiopathic. What's that? I don't even know. Idiopathic, explain that one. We don't know though, because it's idiopathic. So there are some congenital causes of lung abnormalities that will increase your pulmonary vascular resistance, such as congenital diaphragmatic hernia. Yeah. She died. TAPVD, Rachel's straight in there with like it, Rich. And we won't go into types right now. This could go down a rabbit hole. I don't know why I'm talking into my phone because it's the laptop. It's my laptop. I just feel like I'm closer to you if I'm talking into my phone. Ha ha, says Rachel. Okay, so other causes. So there's one really important one to remember and think about. So back in the bad old days, before surfactant, before antenatal steroids, what was the natural history of RDS, surfactant deficient lung disease? So it would fix itself eventually. Those type 2 pneumocytes start making surfactant eventually. How long does it take? 3 days? What is it? Okay, I'm just going to give you the benefit of the doubt. 3 days, that's correct. So 3 days. 3 days. Okay, that's the natural history of untreated RDS. Yeah, and occasionally we'll see that, very occasionally, because you've got a baby who's sort of got a little bit of RDS, but not enough to warrant getting surfactant, maybe a 32-weeker, and just need a little bit of CPAP, and you just know, you look at that baby and they're sitting there with their FiO2 of 28%. And you go, no, Lisa, for you. And you just have to wait, and you wait it out, and eventually they produce their own surfactant, and they're golden. Okay. So that is a situation, to get us back to what we were talking about, that is a situation in which the baby will not produce urine for a long period of time. Doesn't mean to say that their kidneys aren't being perfused. It's because their lungs are not being perfused. Yes? Good. Okay. Another organ, please. Did you say gut? Excellent. So, what are the signs that the gut is not being perfused?
Feeding tolerant.
So raised lactate, I like. Increased aspirates we've got. Not tolerating feed, says Nikki. Yeah. Distended tummy, ileus. Claire says PR bleeding. Yes. Okay. I'll take that. A bit scared. But okay. Yeah. And a raised lactate. Because
Gut is not infused, so it's not juice.
what are the main organs that make lactate?
Muscle, heart, gut,
Cart. Did you say cart?
gut,
Gut. Yeah. For cart. What's that? Yeah. Okay. Muscle, gut, and
heart, brain.
brain. Excellent. I was just thinking. Yes, brain. So those. So if you see a raised lactate, so and Claire's saying PRV secondary to ischemia. Yeah. And of course, NEC is kind of a low perfusion situation for that bit of gut once the vasculature gets damaged. So ileus, bilious vomits and aspirates, feed intolerance. Yeah. Another organ? Liver, excellent. Well done. No problem there. So how do we know if the liver is not being well perfused? Fingers. ALT, okay. So liver function goes off, yeah. And what might we see? Because we have to send that to the lab. What might we see?
Abnormal clotting.
Abnormal clotting. Abnormal clotting, bleeding, DIC. Yeah. Have you ever seen a baby go into DIC in front of your eyes from poor perfusion state? It's the scariest thing. Out of a room full of scary things, it's a pretty scary thing. It's almost the scariest thing. It's quite scary. Don't do it. But abnormal LFTs and clotting in the lab and bleeding DIC. Okay. Another organ then, raised transaminases, said Zana. So Zana was there as well.
So if you took LFTs on a 2-year-old preterm baby, would they have expected abnormal LFTs, or should they be normal unless just poor perfusion to the liver? Anyway, sometimes you'll have abnormal, normal.
Yeah. So for clotting, I mean, so this is the thing for preterm babies. It's obviously the normal range is different anyway for clotting, so that you wouldn't treat that as indicating poor perfusion. No. Another organ. So the brain. So tell me about the brain. How do we know if the brain is not being well perfused?
Level of consciousness.
So we use our modified, I can't say this with a straight face, but our modified neonatal Glasgow coma scale, the guys at home wouldn't have got that, would they? Because I've said it with a straight voice. They see my face. No, it's all.
Yeah,
Okay.
you can, 'cause I've got the video.
No, I think I've turned it off. Anyway, so level of consciousness using our modified neonatal Glasgow coma scale, which is what? So how do we know how do we judge level of consciousness in a baby? Claire says encephalopathy. Yeah. So how do we judge? What are the things that we would see in a baby? Yeah. So what about the tone?
If there is tone, it's not.
Yeah.
No.
So normal tone. So poor tone.
Oh, yeah.
Before poor tone, we might get a situation where the baby's irritable. Yeah.
Difficult to control.
Yeah. So that might be an indication that this baby's starting to get encephalopathic, possibly because of poor perfusion. But very rapidly, the baby's then just going to have poor tone and be very sleepy and not rousable. Yeah. Beware the quiet child, the pediatrician's mantra. Yeah, beware the quiet child. Okay, and seizures. It's probably quite bad. That's fine. Okay. Right, another organ. Sleepy, quiet baby. Says Ashley. Sleepy, quiet baby. Yeah. Another organ.
Right.
So that leaves us with heart and lungs. So how do we know if the heart and lungs are not being well perfused? It's a trick question. How do we? Did you hear what I said?
Yes.
Oh, I'm not being subtle enough. It's a trick question. How do you know if the heart and lungs are not being well perfused? You can tap your answers. You don't know what to say now, do you? You're like, what's he
Well,
saying?
just lungs, so you say like big saps, but then
Yeah, okay.
there was heart involved in actually.
So low SAT, says Claire. So yeah, so if you have inadequate pulmonary blood flow, then you're going to have low SATs. Yeah, it seems pretty obvious. Yeah. Okay. Great. And if the heart is not being well perfused, in a neonate, yeah. So ischemic changes and tachycardia. Now, so this is the bit where I want you to just tease out in your mind the difference between those organs not being well perfused and those organs responding to a low perfusion state in the body, because they are the primary organs to respond. Yeah, does that make sense? So the heart and lungs respond to a low perfusion state, whether or not they are directly involved by saying, beat harder, beat faster, yeah, work harder for the lungs. So heart beats faster, beats harder, lungs work harder, yeah? And they will do that even if the gut is not being well perfused, or the brain is not being well perfused, or some other organ is indicating something's not right here. We demand more oxygen. So the heart and lungs work faster. But equally, if they are not being well perfused, they will work harder. In the case of the heart, that can also get it into trouble. Yeah. So if you have cardiac ischemia, see, that's a very specific thing. We don't see that very often in babies. Has anyone seen a baby with cardiac ischemia? It's quite scary, isn't it? It's in there with the DIC. So, and someone said low SATs tachycardia, and yes, low SATs tachycardia. So all of those things come together as a complex of responses of the cardiorespiratory system to low perfusion. But be aware of the difference then between each of those individual organs also not being well perfused. Okay, and then we end with lactate, and then so what are our causes of poor perfusion? Why do babies have poor perfusion?
Globally poor, or like poor in one organ specifically.
Anything globally poor?
Sepsis.
Okay. Decreased preload, it's a shock. So in what situation might you get that? So categorizing as sepsis, yeah. And sepsis works on so many levels, doesn't it? Sepsis works on many levels. When we think about our definition of perfusion, sepsis really starts to do a number, as the president would say, on every part of the body. So you've got a situation in sepsis where you're going to get third spacing, so you're going to get a reduction in your intravascular volume and your preload. You are going to get pulmonary edema, so you're going to get poor oxygenation. You are going to get acidosis, so you're going to get a shifting of your oxygen, hemoglobin oxygen dissociation curve. So sepsis is bad, if you didn't know that already. So in prematurity, we also have to think about the fact that the baby's heart, as well as being smaller, is just not as good at doing its job. And remember, it's not designed to do the job that it's doing in ex utero life. Suddenly the right atrium is doing things it wasn't expected to do, and the left, the right ventricle and the left ventricle is now working in ways it wasn't expecting to work, and it doesn't function as well. It has less mitochondria. There's poorer vasomotor control as well, and you're more likely to get peripheral vasodilatation, but also an accentuated response to substances that might change that. Relative adrenal insufficiency. So for the first few days of life, babies have a blunted cortisol response. Rapidly improves, but for the first few days, that's there in preterm babies. Clinical conditions, to think about PDAs, left-right shunting. So if you've got shunting off into the lungs, then you're going to have a reduction in your systemic flow. In which babies does that become significant? How do you know it's become significant in a baby, that diastolic runoff? Signs of cardiac failure. So why?
And because you perfuse of coronary diastole.
Yeah, but part of it, yes, is so that's why it can get into trouble. So some babies, even with significant diastolic runoff, are fine. And the reason for that is their left ventricle, for whatever reason, they are so blessed, their left ventricle is able to cope. It can produce enough cardiac output to feed the steel and continue to feed the rest of the organs. Some babies it's not, and then you can see the signs of failure. Yeah, because that left ventricle then is working beyond its capacity, which is why it's useful to have an echo to see what's going on, and that helps our decision making. So one of the things that we look for is left ventricular hypertrophy when we're making a decision about whether or not we want to ligate a duct. NEC, sepsis, chorioamnionitis, any inflammatory condition, talked about vascular permeability, cardiac conditions limiting systemic flow. Yeah, so our duct-dependent systemic circulations where the duct isn't there. Coarctation, plastic left heart. Fetal maternal hemorrhage, so that comes back to what you were saying about hypovolemia. So fetal maternal hemorrhage will cause you to have challenges. Okay. Mindful of the time that we started late, I'm going to move on. And how do we manage poor perfusion? In light of everything that we just So manage and treat the underlying cause, okay? Right? Give you that. So you give some antibiotics for the sepsis.
Yeah. If they're unfilled, then you need to fill them. If it's a flow problem.
Good. What are you going to fill them with?
I mean, also ideally you should probably fill them with some blood if they need to be filled a lot to increase their oxygen current.
Okay, so blood is great. And blood is especially good if there has been loss of blood. So in fetal maternal hemorrhage, blood would be absolutely fantastic. In a situation where, say, you had sepsis or NEC where you were third spacing, you're losing this fluid, not blood necessarily. And yes, you can do something to improve your oxygen carrying capacity of your blood. So giving blood in the first instance is great. There's a limit to that, and you can rapidly overload. So you need to be careful. And in all situations with fluid in a situation of poor perfusion or hypotension, you need to use fluids judiciously. Even if you're not hypovolemic, fluids will help. Why? Because you will use some of the spare capacity in your Starling curve. You're just sitting there waiting. There's a little bit of reserve. You shove some fluid in, increase your preload on the left side of the heart, and the heart can push out more blood. Great. And if you give blood, then that's even better. But there's a limit to that. You start to go off the end of your Starling curve, and that's not going to work. And I think the only other thing I would say about fluid overload, or giving too much fluid, is there is one situation in which you almost can't give enough fluid, and that's NEC. So you need to watch those babies very, very carefully. Okay, so what else can we give apart from fluid? And the guys at home can join in. Nikki said fluid as well, so she gets the prize too. Anyone else?
The first instance you give fluids, and you could give saline bolus. And if that doesn't make a difference in blood pressure, then you have to start thinking about inotropes.
Okay. So Amina says inotropes. That was it. Amina says inotropes, and Katerina says inotropes. And we've got to treat the underlying cause. So inotropes. Increase oxygen carrying capacity of blood. That brings us back to blood actually. So we'll have that one. That's allowed. So improve flow. Oh. So not inotropes. Not inotropes at all. So what do we mean by improved flow? Because didn't we say we weren't obsessed with blood pressure and hypertension? Because we're not obsessed with blood pressure and hypertension. We're more concerned about perfusion. And perfusion is a function of oxygen carrying capacity and oxygenation and flow. So we want to improve flow. Nikki says don't forget FFP and platelets. Yes, correct. Anything? Anyone? Flow. How do we improve flow?
Is it contractility, urgency?
So improving cardiac output will improve flow. Yeah. So then, and Nikki says again, inotropes, consistent inotropes. So, but I want to get away from the idea of inotropes as being the thing that we're obsessed with, because that's inotropes. Yeah, inotropes is a chemical soup. It's a catch-all. It's an ugly and unrefined term to describe a whole bunch of stuff. Because inotropy is a very specific thing, isn't it? Inotropy means what? Improved contractility of the heart. Yeah. So that's a very specific label, inotrope. Am I still there? Am I not there?
Someone took over.
Who's taken over? Stop it, whoever that was. How could they even take over without my permission? That's crazy. Stop it.
Someone took over the meeting, did it?
Okay, no, hang on.
If inotropes improve cardiac output from traits, improve heart rate.
Right, can everyone say it again? Yeah, okay, good. That was weird. That shouldn't happen. Right, okay, so yeah, we'll get onto that in a second. So rather than inotropes, we're going to refer from now on to cardioactive and vasoactive agents. Yeah? So if and you've given some fluids and you're discussing the management, from now on you're no longer going to say, shall we give some inotropes? You're going to say Brilliant. I love it. And everyone at home as well. But the point is, you don't have to, but the point is to refine the conversation into what are you actually wanting to achieve in this baby. Okay? So, of all of our cardioactive and vasoactive agents, the one that we tend to go to most commonly is dopamine, right? We just put it off the shelf. We like it. It's dopamine. Great. And then dopamine's friend, dobutamine, and adrenaline and noradrenaline. And you look at that and you realize how similar adrenaline and noradrenaline are to each other. It's like one Hertz difference.
Oh yeah, is it like the two in the middle?
It's so this is this that's
Hydrogen.
yeah, that's it. That's the difference. So what's the next one? Can anyone at home? Rachel, you should recognize this. What's the next one? Claire's writing furiously to try and beat Rachel to it. Who's it going to be? Who's it going to be? Anyone in the room? Shout out. And Claire gets it. And Nikki gets it. And Jen gets it. Come on, guys. Come on, guys. Come on.
Starts with M.
Starts with an M. Mirano. In another context, you'd have recognised it straight away. Thanks, Rachel. Rachel got there as well. Okay.
That was me.
Oh.
Sue.
Oh, and Sue. Oh, Sue said it starts with an M. Sue, you're on the call. Oh, Sue's here as well.
Of course.
There's a whole other conversation going on here. I'm not going to go there. Right, what's the last one? It's really complicated, doesn't it? Really complicated. It looks positively organic. Hydrocortisone. Hydrocortisone. Well done. No one else got that. Hydrocortisone. We like a bit of hydrocortisone. Well, actually, it's low in the morning. Anyways. Bad joke. Right. So now let's think about what are the effects of these cardioactive and vasoactive agents. Okay. So now we get onto our inotropy and chronotropy and everything else. Okay. So don't forget your receptors. Yeah. So alpha-1 receptors. Ooh, sorry. I realise I haven't been doing that for you. Let me do that for you. Here you go. Well done. Okay. So your alpha-1 receptors, vasoconstrictive. In your peripheral, renal, and coronary circulation. Beta-1 in your heart increases contractility and heart rate. Beta-2 in the lungs and the peripheral and coronary circulation, vasodilatation and bronchodilation. Dopaminergic on the mesenteric renal coronary arteries and phosphodiesterase 3. Just be familiar with 1 and 2, 3 is your favourite. Phosphodiesterase 3. The heart and peripheral circulation, which is an inotropic and vasodilatory effect. So inotropy is what? Increased contractility, we said that. Chronotropy is heart rate, so that's a beta-1 effect. Peripheral vasoconstriction, alpha-1 effect, yeah? And peripheral vasodilatation. Dopaminergic effect, and PDE3. Okay. And what's the last one of all of those? Inotropy, chronotropy,
Lucidotropy.
Lucidotropy! I mean, I was waiting to say that. Beat everyone to it. No one got there. Well done. Lucidotropy. Who is Lucy? And why is Lucy Trophy named after her? That's not rich.
She's very chilled out.
She's
Lucy is
chilled
very
out.
chilled out.
Sue says she's very chilled out.
Is the clue.
And what is the lucitropic effect that we're looking at? It's inotropy and vasodilatation. Yeah. And it's inotropy caused by diastolic relaxation. And what drug causes this lucitropic effect? Milrinone. Yeah. So milrinone works by causing a dilatation of the heart, which allows better filling and hence increased cardiac output, and a reduction in systemic vascular, well, actually, a reduction in vascular resistance. Which vascular bed depends on the day of the week. Who's asking? Okay, we can get there in a minute. A reduction in vascular resistance. Okay? Great. So dopamine. Dopamine. So how does that work? How does dopamine work, guys at home?
Increased contractility and vasoconstriction.
Mm-hmm. Okay, so we've got increased contractility and vasoconstriction. Depends on the dose.
T1.
Okay. Dopamine is not one drug. Dopamine is not one drug. It's 3 drugs. Okay? So when you start dopamine, you need to be aware and you need to be conscious of the effect you are trying to achieve. Because low dose dopamine is going to cause peripheral vasodilatation. It is its dopaminergic effect. And it causes that dilatation in mainly the renal and spinal circulation. The so-called renal dose of dopamine. Yeah? So in very low doses, you're going to see that sort of effects. In a medium dose, then it's going to cause some inotropy. Now, obviously, these aren't discrete. Okay? But in a medium dose, you're going to start to see some inotropy, then increasing, so improving cardiac output. As you start to get onto higher doses, then you're going to start to see peripheral vasoconstriction. Yeah. So it depends on what you're trying to achieve. So if you don't want to cause any peripheral vasoconstriction, then don't use a dose of dopamine greater than 10 micrograms kilo per minute. And in what situations would you not want to cause peripheral vasoconstriction? So in a situation where you already have increased vascular resistance, poor flow, then you don't want to further worsen that flow. Any duct-dependent systemic circulation where there's a risk of pulmonary overcirculation, yeah, HLH coarctation, you whack in tons of dopamine, you're going to push more of that blood across into the pulmonary circulation, and you're going to make the situation worse. So be mindful of which dopamine you're using. Yeah? And these are not made by me. There's this, and I can't remember what her name is, but you can find them all online. But there's these fantastic illustrations of, actually, she labels them just as dopamine low dose and high dose because she doesn't look after their names. But we know better. But to illustrate the difference between different doses of dopamine. Okay. Moving on. Dobutamine. Anyone tell me anything about dobutamine? And those at home as well, if you're still there.
Help with refilling like this in yesterday. So I want to say preload, but I could be wrong, but something to do.
Okay. It can in a roundabout way. What's the one thing you have to remember about dopamine?
decreases HDL.
Decreases SDR. Yeah, before that, it does. Yeah. Dopamine is a made-up drug. No one. Go away and Google cake. Cake is a made-up drug. Anyway, that.
Yeah.
Dobutamine was made in a lab. Okay, and it was supposed to be the ideal cardioactivation. Okay, it's supposed to be the ideal cardioactivation. And why? Because actually, any cardioactive agent has got to deal with the problem of flow. Yeah, so you've got to increase stroke volume, so it does a bit of inotropy. You've got to increase heart rate, so it does a bit of chronotropy. But also, you've got to deal with peripheral vasodilatation. You've got to relax everything. The problem is, it's just not very discriminatory. It just sort of bumbles into the room. It thinks it's awesome because it's this made-up drug, and it causes a massive tachycardia, and it causes everything to dilate and relax. And so the body's own natural mechanism to cause certain beds to constrict to protect other more important beds. It messes with that balance. So dobutamine should be used with a lot of caution. Okay, and it is described as being like, I think that's supposed to be low-key. For any of you who are up on the Marvel Comics universe, go away and watch the series. You've got time now. It's not letting them go out. Disney Plus is awesome. Okay, right. Adrenaline. How does adrenaline work? Harry's left the conversation. It must have been something I said. It's the cake. He's gone away to find cake. Sorry. Increases systemic vascular resistance? Yes. Through vasoconstriction, but mainly it does contractility. Yeah, I mean it acts on all adrenergic receptors. Yeah. So low dose, mainly it's inotropy. Yeah. And then and some chronotropy. And then higher doses, more of an alpha-1 effect. So vasoconstriction. Yeah. So again, you've got to balance your adrenaline as well. A little bit, great. It's a bit of a pick-me-up. Too much, and you're going to cause significant vasoconstriction. Okay. Noradrenaline just does one thing. Just does one thing. Okay. Just alpha-1. That's it. It's a pressor. It is the pressor. Okay. You want pure pressor? You go to noradrenaline. That's it. Okay. You want something that is just going to increase peripheral vascular resistance. You get out the noradrenaline. In which situation might you want to do this? Sepsis, yeah. PVHN. Yeah. Good. Right, milrinone. So, what does milrinone do? I've already said this. Yeah. It just relaxes everything. Yeah. So this is our PDE3, phosphodiesterase 3, and peripheral vasodilatation and pulmonary vasodilatation. And it's synergistic with nitric oxide. We've got a baby with pulmonary vascular resistance, they're on nitric. We're going to improve that. Use of milrinone. What's the caveat? It causes peripheral vasodilatation. Didn't we just say that in PPHN we wanted to increase systemic vascular resistance, not decrease it? So use with caution, yeah, and you might need a bit of pressor to go with it. Balance things out. And it causes coronary vasodilatation. And we already said that it increases cardiac relaxation. And it has a direct inotropic effect. So it's awesome. It's great. Neuronone is really great. Okay. Okay. Right. What about hydrocortisone? How does that work? Just on silence. Okay. Anyone at home? You can tap, tap, tap. So it's a replacement for endogenous cortisol. Yeah. And cortisol acts on the adrenal gland. So Jonathan's right. But what other effects does it have? So we'll
Enhances the alpha from beta
by
increasing sensitivity.
yeah. So you upregulate your alpha receptors in the heart. So you have more of them, and you increase your endogenous noradrenaline and adrenaline. You also increase intracellular calcium, which improves contractility. Also is to inhibit catecholamine uptake and breakdown. And it inhibits prostacyclin and nitric oxide production, reducing inflammation, which obviously we recognize as an effect of a steroid. Okay. And these effects it has in a staged way. So immediately it has an effect on the intracellular calcium, so it improves your inotropy in the space of a few minutes. But most of the other effects happen after 3 or 4 hours. Okay. Summary. It's supposed to be a question slide, then summary slide, isn't it? I feel like it's quite late and I probably need to finish my wardrobe. Okay. Any questions before we do summary then? And for anyone at home as well.
Would that then, what really used to be the thinking of before that second line inotropic, there is, it's whatever you're trying to treat. Is the inotropic. Exactly.
We tend to get into that because we tend to. So what are the sorts of things that we treat? A lot of the time, there's a handful of conditions, and so we get used to reaching for our most common thing. I mean, we tend to use dopamine a lot. You've got to use dopamine with caution. You've got to understand what it's doing and why you're using dopamine. Dopamine in very small babies can have an immediate effect at actually quite low doses. So in preterm babies, even doses of 2.5 to 5 micrograms can actually have a bit of a vasoconstrictive effect as well. It can make your blood pressure shoot up. And you probably missed in the very first slide, you had your blood pressure and brain perfusion graph, which shows that the brain is very good at controlling the amount of blood going into it up to a point. Below a certain blood pressure, then you get a drop off. And above a certain point, it can't regulate either. And so you get a hyperfusion effect, which is the most common injury that we see in the brains of preterm babies. And so avoiding high blood pressure is as important as avoiding low blood pressure. So when we're using our inotropes, we've got to use them with caution, especially in the very small babies, and be aware of the effects and move carefully. Thinking about PPHN, which is another common thing, then absolutely noradrenaline, but think about neuronone if you're going to be on nitric as well. Yeah. And think about using hydrocortisone early. Right. We're going to jump to the summary. So our aim is not to improve blood pressure, but to improve perfusion. perfusion is a function of flow, oxygen carrying capacity, nation of the blood. Yeah. Core perfusion is a clinical assessment. We went through that. Yeah. Management is aimed at increasing the flow of nutrient, oxygen-rich blood to end organs to adequate levels to match what is required. Is that okay?
Yeah.
So,
Fluid frequency is a saline or
use whatever you like, or don't use anything. You can use some saline, but blood. Good. Okay.
Yeah, that's very good.
Thanks, guys. Stop recording now.
Fantastic, Hamad. Thank you.
Thank you. Sorry, I didn't look at the questions.
Hamad,